Hello everybody. Welcome back. Last time we have talked about anemia and how it can be classified. We also have talked about the anemia of blood loss and anemia of increased destruction or hemolysis. Today in this video we will talk about the third type. Anemia due to reduced RBC production. Anemia due to reduced RBC production can be classified into several major categories based on pathophysiology. The most common and important anemias associated with red cell underproduction are those caused by nutritional deficiencies, followed by those that arise secondary to renal failure and chronic inflammation. Also included are less common disorders that lead to generalized bone marrow failure, such as aplastic anemia, primary hematopoietic neoplasms, and infiltrative disorders that lead to marrow replacement, like metastatic cancer and disseminated granulomatous disease. In this video we discuss about the first class. Anemia caused by nutritional deficiencies, specifically about iron deficiency anemia. Deficiency of iron is the most common nutritional disorder in the world and results in clinical signs and symptoms that are mostly related to inadequate hemoglobin synthesis. Before we start talking about the disorder, let's see what normal iron metabolism looks like. The total body iron content is normally about 2.5 gram in women and as high as 6 gram in men, and can be divided into functional and storage compartments. About 80% of the functional iron is found in hemoglobin, myoglobin and iron-containing enzymes such as catalase, and the cytochromes contain the rest. The storage pool represented by hepcidin and ferritin contains about 15% to 20% of total body iron. The major sites of iron storage are the liver and mononuclear phagocytes. Iron in the body is recycled between the functional and storage pools. It is transported in plasma by an iron-binding glycoprotein called transferrin, which is synthesized in the liver. The major function of plasma transferrin is to deliver iron to cells, including erythroid precursors, which require iron to synthesize hemoglobin. Free iron is highly toxic, and it is therefore important that storage iron be sequestered. This is achieved by binding of iron in the storage pool to either ferritin or hepcidin. Iron is both essential for cellular metabolism and highly toxic in excess, and total body iron stores must therefore be regulated meticulously. Iron balance is maintained by regulating the absorption of dietary iron in the proximal duodenum. Iron that enters the duodenal cells can follow one of two pathways. Transport to the blood or storage is mucosal iron. This distribution is influenced by body iron stores. Ferrous iron destined for the circulation is transported from the cytoplasm across the basolateral enterocyte membrane by ferroportin. Iron absorption is regulated by hepcidin, a small circulating peptide that is synthesized and released from the liver in response to increases in intrahepatic iron levels. Hepcidin inhibits iron transfer from the enterocyte to plasma by binding to ferroportin and causing it to be endocytosed and degraded. As a result, as hepcidin levels rise, iron becomes trapped within duodenal cells in the form of mucosal ferritin and is lost as these cells are sloughed. Thus, when the body is replete with iron, high hepcidin levels inhibit its absorption into the blood. Conversely, with low body stores of iron, hepcidin synthesis falls and this in turn facilitates iron absorption. Iron deficiency can result from: first, dietary lack. Dietary lack is more common in developing countries, where food is less abundant and most iron in the diet is found in plants in the poorly absorbable inorganic form. Second, impaired absorption. Impaired absorption is found in sprue. Other causes of fat malabsorption, also known as steatorrhea, and chronic diarrhea. Gastrectomy impairs iron absorption by decreasing the acidity of the proximal duodenum, and also by increasing the speed with which gut contents pass through the duodenum. Third, increased requirement. Increased requirement is an important cause of iron deficiency in growing infants, children, and adolescents, as well as premenopausal women, particularly during pregnancy. Economically deprived women having multiple, closely spaced pregnancies are at exceptionally high risk. Fourth, chronic blood loss. Chronic blood loss is the most common cause of iron deficiency in the Western world. External hemorrhage or bleeding into the gastrointestinal, urinary, or genital tracts depletes iron reserves. Iron deficiency in adult men and postmenopausal women must be attributed to gastrointestinal blood loss until proven otherwise. To prematurely ascribe iron deficiency in such individuals to any other cause is to run the risk of missing an occult gastrointestinal cancer or other bleeding lesion. Whatever its basis, iron deficiency produces a hypochromic microcytic anemia, although at first it might cause normocytic normochromic anemia. At the outset of chronic blood loss or other states of negative iron balance, reserves in the form of ferritin and hemosiderin may be adequate to maintain normal hemoglobin and hematocrit levels as well as normal serum iron and transferrin saturation. Progressive depletion of these reserves first lowers serum iron and transferrin saturation levels without producing anemia. In this early stage there is increased erythroid activity in the bone marrow. Anemia appears only when iron stores are completely depleted and is accompanied by lower than normal serum iron, ferritin, and transferrin saturation levels. Clinical features. The clinical manifestations of the anemia are nonspecific. The dominating signs and symptoms frequently relate to the underlying cause of the anemia, for example, gastrointestinal or gynecologic disease, or malnutrition. In severe and long-standing iron deficiency, depletion of iron-containing enzymes in cells throughout the body also causes other changes, including koilonychia or spooning of nails, alopecia or loss of hair, atrophic changes in the tongue and gastric mucosa, and intestinal malabsorption. Depletion of iron from the central nervous system may lead to the appearance of pica, in which affected individuals consume non-foodstuffs such as clay or food ingredients such as flours, and periodically move their limbs during sleep. The diagnosis of iron deficiency anemia ultimately rests on laboratory studies. Both the hemoglobin and hematocrit are depressed, usually to a moderate degree, in association with hypochromia, microcytosis, and modest poikilocytosis or having abnormal cells. To summarize, iron is absorbed in the duodenum by basolateral transportation using ferroportin, which is negatively controlled by hepcidin. Iron deficiency can result from dietary lack, impaired absorption, increased requirement, and chronic blood loss. In the next video we will talk about the rest of the anemia caused by nutritional deficiencies. Thanks for watching. If you like this video please give a thumbs up and subscribe for more.